Start.
Assalamu alaikum. I'm Dr. Shani Siddiqa. Ladies and gentlemen, participants from home and abroad, good day to you all. I'm welcoming you to first virtual international scientific conference of Endometriosis Adenomyosis Society of Bangladesh, EASB. Our session is Symposium 8 and the theme is being surgery of endometriosis, what to do and what not to do. We are honored to have Professor Shamshad Jahan Shedi and Professor Musammad Dilruba Akhtar as chairperson. Professor Shamshad Jahan Shedi is the professor and head of the Department of Obstetrics and Gynecology, Department of Bardem, Dhaka, and Senior Vice President of ACLSP and Organizing Secretary of Gynecological Endoscopic Society of Bangladesh. Professor Mistress Dilruba Akhtar is the Director and Head of the Department of Obstetrics and Gynecology of Institute of Child and Maternal Health, Dhaka. And our moderator is Professor Kamrunnesa Runa. She is the former professor and head of the Department of Institute of Applied Health Science and Chittagong Medical College. Now, I am requesting our moderator to start her work.
Thank you, Dr. Sharmin. Distinguished delegates, learned audience, ladies and gentlemen from home and abroad, and I welcome all of you in our today's symposium. I, Dr. Kamrunnesa Runa, feel privileged to be moderator of this session. This session will focus light on endometriosis surgery, what to do and not to do. You know, surgery for endometriosis a bit sensitive and skill-based. If the surgery will not be a complete one, it may causes harm to the patient, and if complete surgery can be possible, then it will improve women's quality of life as well as fertility. So this session will focus light on that matter. This session is enlightened with the gracious presence of 3 eminent specialists from abroad. Time allocation for each participant is each speaker 15 minutes. Before the end of presentation, we will give soft reminder 2 minutes before. And all the honorable speakers are requested to maintain their time. If any question from audience, please write in the chat box, and if time will permit, then it will be discussed in the after the speech. Now, actually, it's my honor to invite our first speaker from India, Dr. Vidya V. Bhatt, who is accomplished obstetrician and gynecologist, sonologist, laparoscopy surgeon, and IVF specialist also. She is Joint Secretary of Karnataka Society of Obstetrics and Gynecology 2010, and worked as President Bangalore Society of Obstetrics and Gynecology in 2012 to 2013. Let me invite our first speaker, Professor Dr. Vidya V. Bhatt. Please, I would like to call on screen Professor Dr. Vidya. Please present your paper. Thank you.
Thank you so much, ma'am, for the nice introduction. Namaskar from India to all of you. It's been great to be on your panel and conference. And thank you so much. I thank the Bangladesh Gynecology and Endoscopy Society for giving me this opportunity to share my views on adolescent management of endometriosis. When I say endometriosis in the adolescent girls, it is a big challenge. As it is, endometriosis is a big challenge because you should know when to operate, and is the surgery adequate or not is the question. And sometimes surgery may not be necessary. So all these questions arise when we try to manage a case of endometriosis. When it is an adolescent girl, remember it's a young girl coming to you. Do you have to operate? The challenge is counseling the patient, counseling the child, and the future fertility status of the child. All these responsibilities lie on you. So the most important thing is when to treat and when not to treat, and when to do surgery and when not to do surgery are the salient features where we see what we see in adolescence and endometriosis. So it is the leading secondary cause of dysmenorrhea in adolescent. The therapy should be individualized. As I told you, that we should think about the contraception, then the contraindications of hormone use, and the adverse effects, and adolescent girl and the family, everybody is involved in that. So although the prevalence of the endometriosis is unknown, at least 2/3 of the adolescent girls with chronic pelvic pain, 2/3 with chronic pelvic pain. That is, whenever a girl has chronic pelvic pain, about 40 to 50% you put in a laparoscope and you can diagnose endometriosis. So most of the time when we see these girls, there is a delay. The period begins, the pain starts, but the 3 years goes with just medication. And the first GP visit, that also takes some time. And then it is just injections and medicines. And then sometimes they are referred to surgeons, sometimes they are referred to physicians. To see a gynecologist, they say it takes some time because there is a taboo in mind. Should we go and see them or not? And sometimes it may go as late as 27 to make a diagnosis. So the prime years of 11 years can lead a a small cyst to frozen pelvis kind of situation. So we have to keep in mind that we should start investigating at an early age. So what are these things which come to us when we see a girl with chronic pelvic pain or when we suspect adolescent endometriosis? That is severe dysmenorrhea, whether with OCPAs or not, non-contraceptive use, then the oral tablets, whatever she takes, it doesn't affect her. There is pain during defecation. There is a benign history of a benign ovarian cyst, and there's a family history of endometriosis. So when we say pelvic endometriosis, all of you know that it's peritoneal, ovarian, and deep infiltrating. These are the stages. I will not be going into the detail of it. But how do you investigate this girl? That is, you do a transvaginal scans. Well, in an unmarried girl, it is not advisable. But a transrectal scan can be done. And CT and MRI, when you need a higher investigation mode, color Doppler, wherein it shows increased vascularity. Suppose there is hematuria, then do a cystoscopy and see. And if there are bowel symptoms, a sigmoidoscopy, and of course the anti-endometrial antibodies and TNF and all, which is not done. But most of the time, a scan can give a diagnosis. Suppose that pain continues even after you see a normal scan, get an MRI done. Though expensive, it is one of the good diagnostic tool for endometriosis. So treatment option, adolescent endometriosis, when you see mild or you see a small cyst, the patient is comfortable, or if there is pain, you put them on medical therapy. Surgical therapy, when? That is, you're treated medically, that is hormonal, progestrogens, antigens, GnRH, whatever, anti-progestrogens, everything you're treated, but there's no improvement. And there is a large cyst which is sitting, that and which is causing discomfort. Such cases, you have to consider surgery. That is NICE guidelines of 2017. When a trial of NSAID fails and when initial hormonal treatment is not effective, then you have to go in for endometriosis. So this is, surgical management. This is a girl who came to me with large cyst. Actually, it was diagnosed as fibroid. But when she came to me, because of the tense abdomen, I'll show you the abdomen, how it was in my next slide, but huge cyst. But the cyst was exophytic. It was not within the ovary. So the thing was easier, because when you have to do a cystectomy, that time there is a lot of damage to the ovary caused. But if it is an exophytic cyst or the type 2 cysts of endometriosis, which is not involving the ovary, because of ovulation, it appears like that. That was a normal ovary. You see a lot of, depressions there. That is the normal ovary. So we separated the cyst with the harmonic. There were multiple cysts, so which small cysts also was there. So we removed it, and then suturing is the most important thing. Of course, because it's an exophytic cyst, I'm using the harmonic. But into the ovarian tissue, never use harmonic or cautery, because that will cause a lot of damage to the ovaries. So the exophytic cysts were removed, and then we sutured the raw areas. See, the ovarian function was maintained, the ovarian tissue was not touched, and then we sutured it. And the most important thing is, how do you remove it? Now you have got a cyst which is sitting there, and you take a stitch, suture it, and then you have to put it into an endo bag. So you can see me suturing the raw surfaces and achieving good hemostasis. Don't cauterize that area. And then all this is put into an endo bag and removed. And this was the post-surgical outcome. She came to me with a mass, and we did an MRI, and we found that it was an endometriotic cyst. And this was post-surgery. And the girl is doing very well. This so many years back, if this was no recurrence, we put her on medical therapy, and look at the amount of endometriotic fluid which we removed. And then there's another large cyst which this girl came with, huge cyst with pain, severe pain abdomen. And then when we put in the scope, we had diagnosed that it was an endometriotic cyst. So sometimes, to get a better view of the pelvis, what you have to do is, with your first port only, you can aspirate these cysts. And then the challenge is, now this was a cyst which was not exophytic, it was within the ovary. So the type 1 kind of cyst. Now what we do, we just open up the cyst, and the problem is, when it's a huge cyst, when you're trying to peel it off, look at the amount of bleeding. Well, I did not use any cautery. I don't believe in using. Sometimes, yes, it bleeds. You can see it is scary when you see a pool of blood because of the bleeder there. But we normally don't take sutures. What we do, we normally don't use the cautery. What we do is, we aspirate completely. And once everything is aspirated and the cystectomy is done, catch hold of the bleeder with suturing. So you can also put a clamp there initially. And this is how, it was a huge cyst. So this is how we sutured and reconstructed the ovary. That is very important. You can't just leave that ovary there. You reconstruct it. Of course, if you cauterize, there is a damage, but you reconstruct the ovary, restore the anatomy. See, all this was the open cyst. We gave a good lavage and came out. And this girl, we put her on post surgery. We put her on medical therapy, and we call her for follow-up every year. And the girl is doing very well. The most important thing is, till they get married, of course, we have to tell them early marriage and childbirth and all that. But at least we can always see to it that do a follow-up, which they may not like. You tell them get married early, they may not like. At least we can do a follow-up and put them on medical therapy and see that there is no recurrence. Now, this was another huge cyst which this girl came to me. It looked almost like a frozen pelvis. We couldn't feel anything when we did a rectal examination. And this was a large cyst. And how to do this? Now, what we did was, we injected vasopressin and then aspirated the cyst. This is another way of doing it. You inject vasopressin. In a large cyst like that, it may be difficult, but compared to the previous one, this is a smaller one. And once you aspirate it, of course, you can see all the deep infiltrating endometriosis behind. But that was also taken care of. You open up the cyst and then peel it off. And once you peel it, you can see there's hardly any bleeding. When you give vasopressin, 10 units in 100 ml of normal saline, and you can see me peeling the whole cyst there. And then once the cyst was peeled completely, we reconstructed. We cauterized all the areas of endometriosis and then reconstructed the ovary and removed the cyst in a from the endobag. And then, of course, now I believe in putting this oxidized regenerated cellulose, which will prevent adhesions and the post-op adhesions, whatever you see, that can be prevented by this. And deep infiltrating endometriosis. This girl had adenomyosis, and I was treating her medically. That is, I was treating her with GnRH and Dynogest, but she was not responding. And since she was not responding, I just put in the laparoscope because of her pain. Every cycle was a nightmare for her, and we could see that deep infiltrating endometriosis. So when you want to avoid bleeding, where I normally like to use the scissors here because of the bowel. Look at the bowel being so much adherent to the posterior wall. So I inject vasopressin 10 units in 100 ml normal saline, about 20 to 30 cc. Of course, you have to tell your anesthetist that you're injecting vasopressin, and all the infiltrating endometriosis in the posterior wall of the uterus was removed. And then her adenomyosis also, we treated her for quite some time with GnRH and Dynogest. She didn't respond. And then after a proper counseling and after this surgery, I put her on Mirena, and that girl is doing very well now. She comes for follow-up regularly, and there's no pain after a proper clearing. And we put the interseed, that is oxidized degenerated cellulose, into the posterior wall, and the girl is doing fine now. So all the adhesions, everything was released, and the uterosacrals were separated, and the deep infiltrating endometriosis to the bowel was separated, and the girl is doing fine. Only thing is, be careful. Don't try to do heroics in these girls, because if this girl lands up in injuries, then they will go into ileostomy or colostomy. That is very dangerous. So one has to be careful. If one is not well versed with this, it is better to call a surgeon who's well versed in that surgery. So Mullerian anomalies and endometriosis is quite common. When there is obstructed Mullerian anomaly, you can have retrograde endometriosis like this. There is some obstruction here, and then this cavity is normal, but there is obstruction. So that can lead to endometriosis. And in such cases, you will have to treat it. In case like ovira is obstructed hemivagina and renal agenesis. So this girl came to me with saying that a large endometriotic cyst, and we got a CT done, and there was right renal agenesis. So that time my radiologist took a MR sections also, and then we realized it was ovira because there was renal agenesis. And this case, if we had not diagnosed, probably we would have been in trouble. That is gone in, and maybe we couldn't do adequate. But all we had to do was open up the hemivagina, and then we saw that there was a large septum. And at this age, we didn't remove the large septum. We just looked for endometriosis. And once the uterine anomaly is treated, endometriosis automatically disappears. And you can see that endometriotic spots there. But we just put her on medical therapy, and the girl is doing fine. In a rudimentary horn, this is sometimes dangerous. There is a rudimentary horn, there is retrograde endometriosis, there is an ovarian endometriotic cyst. Now what happens, this cyst was completely gone with the complete, almost a hypoplastic kind of ovary and a complete cyst there. So we removed the tube and the cyst and the rudimentary horn. The other side, it was normal. So this was causing a lot of discomfort. That is why we had to remove it. And that complete ovary was gone on ultrasound. And then what we did was, this was a non-connecting rudimentary horn. Whenever you're removing a rudimentary horn, we have to be careful. Open it up in a V shape, in a wedge-shaped manner. Remove the cavity which is causing the problem. But try to keep the myometrium, because if you try to shave off the myometrium also, there could be problems to the blood supply. So always remove in the wedge-shaped pattern, and you can see that the cavity is completely removed and obliterated. And then once you completely remove the cavity, once you completely remove the cavity of the rudimentary horn, just trying to fast forward it. Yeah. No, I finished that.
Yeah. 2 minutes more,
yes,
ma'am.
Yes. This is my last video.
Okay, thank you.
and then suture it. See, when you're reconstructing, this is the most important thing. Now we are using barbed sutures. Initially, we used to use the Vicryl. Now, once you start reconstructing it, look as though it looks like a normal uterus. So normally placed uterus, there's a nice cavity there, and the right side tube and ovary is normal, and the disease is taken care of. So in adolescent girls, the new concept is now ovarian tissue cryopreservation. There are many series. They're saying that we should be doing ovarian tissue cryopreservation, but it is not approved completely. People are still debating on that. So maybe this will be the future. If we see a young girl with bad endometriosis, we may have to do ovarian tissue cryopreservation for future fertility or oocyte cryopreservation. So that also may come in future. But don't do lab for, generally I tell you, PCOS, asymptomatic myomas, adenomyosis. When there is a diffuse adenomyosis, please don't put in laparoscope, small follicular cyst, and asymptomatic congenital anomalies, please don't do laparoscopy. This is the ASRM guidelines, which has been summed up. Whatever I've told you, it is the summary of that. That is the recommendation and conclusions. Only when it is necessary, we will have to evaluate. So pelvic pain in adolescent girls has to be evaluated. Non-invasive investigations has to be done whenever necessary. Laparoscopy should be carried out in indicated cases. And in adolescent girls, the problem should be tackled by a skilled surgeon whenever surgery is absolutely indicated. Thank you very much for your kind attention.
Thank you, Dr. Vidya, for your excellent presentation and sharing your videos with us. I hope all our audience will be gainer from this presentation. Thank you so much.
Thank you so much, madam. Okay. Thank you for the opportunity.
And we have seen lots of video from YouTube. Your video is there.
Yes. Thank you. Thank you.
Thank you. Now it's my honor to invite our second speaker of this session from Japan, an eminent Professor Akira Iwase, Professor and Chairman, Department of Obstetrics and Gynecology, Gunma University School of Medicine, editor of Journal of Reproductive Medicine and Biology. He is honored as board member of different professional societies of Japan, that is Japan Society of Obstetrics and Gynecology, Japan Society of Reproductive Medicine, Japan Society of Fertilization and Implantation. So he will present his paper on best practice for endometrioma surgery. Please welcome Professor Akira Iwase.
Hi, thank you for introduction. Okay, let me start my video. Is that okay?
Yes. So video not playing. Okay. So.
We can hear anything.
Sir, should we share from our side? We can't hear the audio.
Sound.
Okay.
No sound.
No sound?
No sir.
Yes. Uni bolbe, mukhe bolbe, Runapa. Uni mukhe bolbe. Yes, it's audible, sir. Audible.
Okay, so you can hear my voice, right?
Yes, sir. Thank you.
But so you cannot hear my video, right?
Yeah, yes.
Okay, so all right. Okay.
We also have your presentation in our hand. If you want, we can share from our side so we can overcome the technical difficulties.
Yes. Okay. I send you my video in advance Could you
Yeah.
play the video
Yes, I
at
have.
your side?
Yeah. Tushar, would you please share it?
It is my
You can.
great honor to have this opportunity. I appreciate Endometriosis Adenomyosis Society of Bangladesh and the organizing committee of the conference.
Thank you, sir.
You know, the national flags of Bangladesh and Japan are very similar, the same design in different colors. I found another similarity, it is the shape in the map. This is Bangladesh. This is Gunma Prefecture, I live. The shape in the maps are a little bit similar, like flying birds. I have nothing to disclose. Cystectomy has been a gold standard for endometriomas. Endometrioma consists of heterotopic endometrium and retained product that shouldn't be there. Then, what shouldn't be? Should be removed. Of course, the story is more clinical. I showed the meta-analysis by Hart in 2008 as for spontaneous conception after surgery. Cystectomy is superior to ablation. However, we should keep it in mind that the ages of recruited women in two studies were rather young, like from 28 to 30 years old in average. In Japan, we often see women with endometriosis seeking infertility treatment. 30 or 32 years old is okay, but how long the women over 35 years old can spend in tension of spontaneous pregnancy. As you know, endometrioma surgery, especially cystectomy, may affect ovarian function. I'm showing the meta-analysis in 2012. You can see the decline of AMH levels after cystectomy. For me, the date is not enough. They didn't distinguish one side or both sides. In 2012, I also gathered the data showing in the slide now. I distinguished unilateral cases and bilateral cases. Unfortunately, I didn't know how to do meta-analysis then. Unilateral surgery or bilateral surgery may cause the big difference in postoperative AMH levels. Another meta-analysis on this topic demonstrated bilateral surgery caused significantly greater decrease in AMH levels compared with unilateral surgery, and the difference is estimated about 1 nanogram per ml of AMH. The graph is showing age-dependent decline in serum AMH levels among infertile women. After unilateral cystectomy, AMH levels are like this, and bilateral cystectomy causes severe decreases. Another study reported 3 out of 126 women undergone bilateral surgery caused ovarian failure, and their ages are 31, 33, and 39 years old. We should be careful when thinking the indication of bilateral cystectomy over 30 years old women, even when they have median class of AMH levels for their age. We know the story is different for women seeking assisted reproduction. As I'm showing in the slide, several meta-analyses did not find the significant differences in pregnancy rate or live birth rate in assisted reproduction after cystectomy. So, indication of surgery prior to assisted reproduction is independent of fertility issues. I don't think so. Several retrospective studies reported lower pregnancy rate in women with diminished ovarian reserve after endometrioma surgery or repeated surgery compared with their counterparts. As for non-assisted reproduction, two studies demonstrated lower pregnancy rates in women with lower serum AMH levels after cystectomy. Another one reported that preoperative AMH can be a predictor for cumulative pregnancy after cystectomy. Although the evidence is not sufficient, we may say that lower AMH levels less chance of pregnancy after endometrioma surgery. Then we should consider again the indication and surgical technique, especially ovarian reserve friendly approach. I'm showing the recommendations of SG, Eschle, and West about surgical technique for endometrioma. Several important points during cystectomy are listed, and combined technique and 2 or 3-step approach are also introduced. How about hemostatic method? Non-thermal hemostasis has been shown to be favorable compared to bipolar electrocoagulation. I can say it is a matter of course. In my opinion, best practice for hemostasis is dependent on the type of bleeding. So anyway, use of electrocoagulation should be minimized. Combined technique is literally combined with cystectomy and ablation vaporization. Evaluation using antral follicle count of the ovaries showed similar AFC levels compared with intact site. Also, conventional stripping method. I'm not sure, but this technique does not seem so bad. I'm showing the very recent case of cystectomy, like 2 weeks ago. The case is rather difficult. She underwent pelvic inflammation, probably following rupture of cyst 2 months ago. So finally, I would like to refer the interventions combined with hormonal treatment and surgery. A three-step approach goes like this: drainage and inspection as the first surgery, and subsequent hormonal therapy is applied, and then surgery again. In 2010, three-step approach combined with GnRH agonist and CO2 laser vaporization showed better postoperative AMH levels compared with stripping technique. So I'm showing our randomized trial comparing GnRH agonist and GNGest that were used both of preoperative and postoperative period. So we found that higher AMH levels 14 months after surgery with GNGest treatment. This is a final slide. Fertility issues in women with endometrioma. It's common, but not so simple. Cystectomy is best for someone, not for everyone. And ovarian reserve is important. However, the data related to live birth rate is limited. And surgery for endometriomas is often more difficult than expected. Thank you for your attention. Thank you. It is my great honor to have this.
Excellent. Excellent. どうもありがとうございます。
ありがとうございます。
My heartfelt thanks to you, sir, because you have explained so nicely and sharing your experience with evidence. So I hope what will be the best practice, our audience will be enrich their knowledge regarding this issue. Thank you, sir.
Thank you.
Now, let me introduce the third speaker of this session. Again, he is another speaker of this session from Japan, Professor Atsushi Fukui, who is specially appointed Professor Fukushima Medical University, and he rewarded and honored from different society like Japan Society of Endometriosis and American Society for Reproductive Immunology Travel Award. And he will speak on sclerotherapy for infertile women with endometriosis. I think our audience are very much eager to hear from you that it's a bit new horizon for endometriosis treatment. So welcome, Professor Atsushi Fukui. Please, sir, present your paper.
Thank you, Chairman. Thank you very much for inviting me for great first virtual international scientific conference. Congratulations for ENDO Bangladesh 2021. And today I'd like to introduce laparoscopically assisted ethanol sclerotherapy. So I'll start my presentation. I'd like to share please wait. And does it work?
Thank you very much.
Can you hear my sound?
Me a great opportunity to present my work. My name is Atsushi Fukui from Hyogo College of Medicine. For women with endometrioma who need to keep the ovarian function, it's very important how to deal with ovarian endometrioma. Today, I'd like to present laparoscopically assisted transvaginal ethanol sclerotherapy for ovarian endometrioma as a gentle and reasonable treatment for ovarian endometrioma. I have nothing to declare. Today, first, I'd like to show you why pelvic endometriosis causes to infertility. Then, I'd like to introduce our surgical approach to prevent ovarian damage, laparoscopically assisted transvaginal ethanol sclerotherapy, LATV-ESD. Finally, I'd like to tell you the clinical outcomes of LATV-ESD. First, pelvic endometriosis and infertility. This year, Japan Society for Obstetrics and Gynecology published the general rules for clinical management of endometriosis. If infertile women with endometriosis have surgical indications such as severe dysmenorrhea, laparoscopic operation will be performed. At this time, it's very important how to keep the ovarian function, and we need to avoid the reduction of ovarian function. Why does endometriosis cause infertility? There are several reasons. Pelvic adhesions impair oocyte release from the ovary or inhibit ovum capture of transport. For this situation, adhesiolysis is needed. It's reported that there are increase of peritoneal fluid inflammatory cytokines such as IL-1, IL-6, and TNF-alpha, and the increase of peritoneal fluid angiogenic cytokines such as IL-8 and VEGF. For this situation, peritoneal lavage is needed. So laparoscopic operation is very effective for infertile women with endometriosis. Moreover, impaired implantation, endocrine abnormalities, and lower oocyte and embryo quality are reported. Let me consider the benefit and disadvantage of surgery for endometriosis. The benefits of surgery are prevention of possible ruptured endometrioma, facilitation of oocyte retrieval, detection of occult malignancy, avoidance of contamination of follicular fluid with endometrioma content, and prevention of progression of endometriosis. However, the disadvantages of surgery are not only surgical trauma, surgical complications, economic costs, but also potential decreased ovarian response and lack of evidence for improved IVF pregnancy rates. So, what is the most effective and kind of operative method for ovarian endometrioma? How does ovarian endometrioma develop? Adhesion between ovarian cortex and ovarian fossa by endometriotic lesion. Endometriotic lesion produces a fluid. Ovarian cortex is extended by the fluid. So ovarian endometrioma is a pool of concentrated fluid and the extra ovarian pseudocyst. Usually, for ovarian endometrioma, excision surgery, that is cystectomy of ovarian endometrioma, is performed. Excision surgery for endometrioma resulted in a more favorable outcome than drainage with electrocoagulation regarding the cyst recurrence or symptoms, as well as the response to ovarian stimulation and subsequent pregnancy rates in infertile women. However, stripping of the cyst wall may result in ovarian reserve damage due to the removal of healthy ovarian cortex and thermal destruction of ovarian follicles by excessive use of bipolar coagulation for hemostatic purposes. This slide shows the causes of follicular loss during surgery for endometriomas. By the cystectomy, significant number of follicles are stripped. Moreover, coagulation and injuries of blood vessels, edema, and inflammation are another causes. Next, I'd like to show you about LATV-ESD. Ethanol sclerotherapy is the therapeutic use of ethanol in the controlled destruction of undesired target tissues, including the epithelial lining of the true cysts. At the time of ethanol sclerotherapy, we aspirate the fluid and wash the cyst using saline. Finally, ethanol injection is performed. Problems not laparoscopically assisted transvaginal ESD for ovarian endometrioma were reported. They said that ESD causes to severe and unusual adhesions surrounding ovaries due to ethanol leak. For this, if we choose laparoscopy, intraperitoneal saline prevents a leak of ethanol. The possible toxicity of injected ethanol to ovarian cortex has not been completely excluded. For this, We evaluated the fixation time to prevent ovarian damage. They said the lack of available histology made this procedure undesirable. For this, if we choose laparoscopy, we are able to inspect the cyst wall and do biopsy. So laparoscopically assisted transvaginal ESP solves the problems and also allows for intra-abdominal procedures. Where are endometriotic lesion and follicles located in? The thickness of endometriotic lesion is about 80 micrometer and the follicles are located about 300 micrometer. So we evaluated the fixation time. Thickness of endometriotic lesion is 27 to 128 micrometer. By 7 minutes fixation, it's possible to fix about 120 micrometer of cyst wall. So we decided to fix the wall for 7 minutes. This slide shows the reason why we perform not transabdominal centesis, but transvaginal centesis. By transabdominal approach, it's difficult to puncture if there are severe adhesions. Moreover, there is a possibility for the collapse of the cyst, and the ESP becomes impossible if the cyst collapses. So transvaginal puncture is more appropriate for the peritoneal approach, considering the way the cyst is formed. ESP with laparoscopy by transvaginal centesis. 7 minutes fixation by 99% ethanol is the best. I'd like to show you the LATV ESP case. She was 32 years old nulliparous. Chief complaint was child hope. She visited our hospital for further evaluation of pelvic endometrioma. She had 49 millimeter and 25 millimeter of endometrioma in right ovary, and 42 millimeter of endometrioma in left ovary. Vaginal examination showed induration and tenderness at Douglas Porch. This is a procedure of LATV ESP. The small pelvic cavity was filled with approximately 1,000 aligned. In order to prevent issues with the right ovary. The endometrioma was transvaginally and the transvaginal ultrasound and the chocolate-like fluid was aspirated manually. Then they were washed using physiologic saline. 99% absolute ethanol of approximately 80% volume of fluid aspirated from the endometrioma was injected and fixed for 7 minutes and washed using saline. A uterine manipulator was placed into the uterus. To avoid the rupture of the endometrioma, all of intraperitoneal operation was performed after fixation. Treated ovaries were peeled off from the ovarian fossa and the capsules were exposed to confirm that the 4 lumen were fixed and with ethanol. A biopsy was performed to confirm histologically. Additional adhesiolysis, cauterization peritoneal lesions, chromotubation, and intraperitoneal lavage were performed. To avoid the adhesion, we use adhesion barrier. It's called separati. Three cycles after operation, she got pregnant naturally using ovarian stimulation using recombinant human FSH and delivered healthy baby. Finally, I'd like to show you the clinical outcomes. Objective of this study is to evaluate the effectiveness of ethanol sclerotherapy for infertile women with endometrioma. We evaluated post-operative recurrence, pregnancy outcome, and outcomes of IVF-ET. 117 infertile patients undergoing laparoscopic operation for endometrioma. Excision group 47 patients, LATV-ESD group 70 patients have entered for this study. We followed post-operative course at least for 2 years. There are no differences in the patient characteristics between two groups. This slide shows recurrence of endometrioma. Recurrence rate in ESD group was significantly higher than excision group for 2 years follow-up and long time follow-up. This is pregnancy rate and natural pregnancy rate between two groups for 2 years and 2 years and more. There was no significant difference in pregnancy rate between excision group and LATV-ESD group. This is the reactivity to control the ovarian hyperstimulation in IVF cases. Dose of FSH and days of FSH were significantly lower, and the endometrial thickness was higher in ESD group, but there was no difference in number of follicles and oocytes. This is a comparison of bilateral ovarian endometrioma cases and unilateral ovarian endometrioma cases. Dose of FSH and days of FSH were the highest in bilateral excision group. This slide shows outcomes of IVF-ET. There was no significant difference in pregnancy rate between excision group and LATV-ESD group for 2 years follow-up and long time follow-up.
Only 2 minutes more, sir.
Thank you.
However, in bilateral cases, pregnancy rate is low, even though ART is applied to them. Careful attention should be paid to handling bilateral endometrioma. Although the post-operative recurrence rate in LATV-ESD was higher than excision, but the total dose of FSH required in the ESD group in IVF-ET program was smaller, so LATV-ESD was less invasive. Our prospective study demonstrated that LATV-ESD was considerably equal to cystectomy with respect to post-operative fecundity. Ovarian damage by excision for bilateral ovarian endometrioma cases was high, so LATV-ESD may become less invasive and effective treatment for especially bilateral cases. This is the conclusion. LATV-ESD is reasonable treatment for infertile women with ovarian endometrioma with surgical indications. LATV-ESD is possible to treat endometrioma. It's possible to inspect intraperitoneal field. It's possible to do histological inspection. It's less damage for ovary. It's a low risk of ethanol leak, so it's equal risk of post-operative adhesion, and it has good fecundity. Thank you for your attention.
Thank you very much.
どうもありがとうございます。
ありがとうご
Thanks
ざいます。
indeed. Actually, all our speakers presented so nicely and briefly explained their experiences. Thanks indeed. Now it is the time for question answer. Actually, due to time constraint, just I will take 3 questions for 3 speakers. My first question to Vidya. Vidya, are you here? Hello? Hello, Dr. Vidya, are you here? Okay, so my second question to Dr. Akira. Professor, please, actually it's one of my patient, one adolescent girl. She had surgery for endometrioma before her marriage. now again recur after marriage along with fertility issue, and both her endometrioma size 4x3 and another one bilateral endometrium, another one 4x5. Actually, what will be the best option for this girl?
So you mean the recurrent endometrioma with
Yes,
4 to 5 centimeter?
yes.
Okay, so if it the unilateral endometrioma, maybe the cystectomy would still be an option. But she had bilateral endometriomas. Maybe I wouldn't recommend cystectomy. However, maybe we should evaluate the ovarian reserve using the AMH or AFC. If the ovarian reserve is good, cystectomy would still be an option, but I'm not sure. It depends on the patient age and ovarian
Yes, sir.
reserve.
22, yes, sir.
Yes,
And
22,
she
okay.
wants child.
Okay, all right. Okay, it's a
bit difficult case, sir.
difficult case.
Yep.
It's too difficult, so I cannot answer to shortly.
Okay, so thank you, sir. So my another question to Professor Atsushi Fukui. What is the fertility outcome after sclerotherapy versus laparoscopy?
Laparoscopy.
What is your opinion, sir?
Laparoscopy means a cystectomy or something.
Yes.
Or, in my presentation, I have already showed, but the pregnancy rate between laparoscopically assisted adenosclerotherapy and laparoscopic cystectomy
yes.
is almost similar. But recurrence rate is high for ESD. But for our Dr. Iwase also presented that bilateral case is very dangerous case for ovarian reserve.
Difficult, yes.
So I think one of the options for bilateral case of endometrioma who have infertility is adenosclerotherapy. Cystectomy for natural pregnancy, the cystectomy is one of the options, but every time we need to consider about the ovarian reserve.
Yes, so we can preserve previously oocyte preservation can be done before the doing surgery, I think. Okay, sir, what is your opinion regarding laser treatment of endometrioma?
What kind of treatment?
Laser treatment.
Laser treatment. You mean laser coagulation or laser?
Yeah. Does it causes reduce the ovarian reserve or not? Yeah.
For laser treatment, recurrence rate is also high compared to cystectomy, but we haven't experienced about laser coagulation, but we have sometimes do using argon plasma coagulator, argon plasma. So argon plasma is the deepness is not so only surface coagulation. Yes. So at the time of you need to do electrocoagulation, I often use argon plasma coagulator, not monopolar, not bipolar.
Okay, thank you, sir. Now my question to Vidya. Vidya is here. I have seen her. Hello, Dr. Vidya,
yes,
are you here?
Yes, yes.
One question for you, ma'am.
Yes, ma'am.
That for adolescent girl, do you prefer Dynogest? Which one is now we using in our day-to-day practice rather than the surgery, and for how long?
Yeah. In adolescent girls, we do not want to give GnRH. Ideal now, Dynogest is quite commonly given, and there are studies which can be given up to 2 years, and there is one study which says up to 5 years. But you can't give long-term Dynogest therapy in our country because one thing is it is a little expensive. So what we do is we give them for about 6 months to 8 months, and then maybe we switch over to cycles of progesterones, that is dydrogesterone, and then Maybe once there is complete regression, then we observe them for 1 or 2 months and then put them on OC pills, which has Dynogest combination.
Thank you very much, madam. So now it's the time for our honorable chairpersons. Now I would like to request our chairperson, Professor Shamshad Jahan, to make some comments and express her thoughts on Dr. Vidya V. Bhatt's presentation. Please, Professor Shamshad Jahan, ma'am. She's the professor and head of gynecology and obstetrics, BARDIM, and senior vice president, EASB. Professor Shamshad Jahan. Madam, are you here? Professor, okay, thank you. Please comment on Dr. Vidya's presentation.
Recording.
Okay, so I think there is some problem. So we can go to our second chairperson, Professor Mosammad Dilruba Akhtar. Madam, are you here? Hello?
Madam, you have to unmute.
Yes.
Professor,
Yes, I can hear.
Okay, okay. Professor Dilruba, please make your comments on second and third presentation, please.
Thank you, moderator, Professor Kamrun Nisaruna. And a very good afternoon to you all of the first virtual international scientific conference organized by Endometriosis and Adenomyosis Society of Bangladesh. First of all, I'd like to give my special thanks to Professor Samina Chaudhary Madam and Professor Saleha Begum Chaudhary Madam for selecting me as a co-chairperson in this session, interesting and time-demanding session, what to do and not to do for surgery of endometriosis. I'd like to give my special thanks to the eminent speakers for their excellent and elaborate presentation on the surgery of endometriosis, what to do and not to do. It is a great pleasure for me to make some comments on the presentation of the renowned speakers. And now I'd like to say a few comments on the topic, best practice for endometrioma surgery, presented by Professor Akira Awase. And he has nicely delivered her all aspects of surgery of endometrioma, when to do surgery, types of surgery, technique of cystectomy, and advantage, disadvantage of surgery. And we have enjoyed her excellent videos of cystectomy, and he showed the meta-analysis result of decreasing AMH level after cystectomy, and the result of cystectomy is independent with pregnancy report. He also discussed about the best practice for hemostasis and advised to minimize electrocoagulation in this method. And we know the surgery remains the mainstay of modern management of endometriomas. And the best way to get rid of an endometrioma to excise by laparoscopy. And first surgery is the best surgery because the multiple surgery decreases the ovarian reserve and ultimately lead to premature ovarian failure. And thank you, Professor Akira Awase, for your nice and excellent presentation. Now I'd like to say something on the next presentation on the topic of laparoscopic ethanol sclerotherapy for infertile women with endometriosis, presented by renowned speaker, Professor Atsushi Fukui. I'd like to give my special thanks for her nice presentation. He delivered a brilliant presentation regarding laparoscopic ethanol sclerotherapy and its many aspects. We have gathered sufficient knowledge from his elaborate presentation. And the newer technique, laparoscopic aspiration and ethanol sclerotherapy as endometriosis for endometriomas, even patients with bilateral endometriomas or with associated deep endometriosis, result in a good success rate and reduced recurrence rate. And another way of non-invasive way is the ultrasound guided aspiration and ethanol sclerotherapy. He has nicely described. He also described the surgery of endometriosis, the benefits, disadvantages, and problems of excised surgery and causes of follicle loss after endometrioma surgery. And however, how much surgery and which technique is employed when it is offered, it can make a dramatic difference in the ultimate success of treatment. There is no question that when minimally invasive conservative standard technique for excision of an endometrioma can result in permanent damage to the ovary. The Boston Center for Endometriosis explored new ways to treat this challenging condition, that is the computer-assisted technique, reproductive surgery, to preserve fertility as a safe method and enhance quality of reproductive life. Thank you very much all again. Thank you.
Okay, thank you, Madam. Professor Shamshad Jahan, Madam. Now I would like to ask again Professor Shamshad Jahan, our chairperson, to make some comments on Dr. Vidya's presentation. Professor Shamshad Jahan.
Thank you very much, Dr. Rona, Professor Rona Appa, for giving me the opportunity. Assalamu alaikum. Let me express my gratitude to the organizers for having me as chairperson in this fascinating session. It was a magnificent participants presentation by all these speakers. The presentation was really subjective and informative, and they have provided all the recent data and techniques on our surgical aspect of endometriosis. I want to thank Dr. Vidya Vivgat for her nice presentation. We have seen in her presentation of MERA and other congenital abnormalities and embryological abnormalities causing endometriosis in adolescent girl, and how nicely managed by laparoscopically, and surgery is the mainstay in these cases, deep infiltrating and endometriosis of adolescent girl. Just in the last week, a young medical student, 18 years old, came to me with severe lower abdominal pain, severe dysmenorrhea, and backache for the last 2 years. Had this patient came to me 2 years back, I put the 20 years back, I put the diagnosis of endometriosis at the bottom of the list of my differential diagnosis. Over the years now, I have known this endometriosis, one of the leading cause of secondary dysmenorrhea over or even in adolescents girl. Seeing is believing. As a laparoscopic surgeon, I have the experience of looking at the laparoscopic view of endometriosis in many of my cases over these years. In my particular patients, I also had the same experience of finding endometriosis, what initially was suggested by ultrasonography and MRI. As similar to many of my cases, I also decided to do laparoscopic surgery in these patients, since she had huge endometrioma with frozen pelvis, which was responsible for her bigger endometriosis and for her unbearable symptoms. Surgical options in adolescents, better to do laparoscopically better than laparoscopically. At laparoscopy, most adolescents are diagnosed with early stage of endometriosis, although there are a number of young patients presenting with more advanced disease, like my cases, and just we have seen in Vidya Bhatt presentations. Patients with endometriosis, I have one suggestion, who have pain refractory to conservative surgical therapy and suppressed hormonal therapy often benefit from at least 6 months of generate and agonist therapy with advanced medicines after laparoscopic surgery. A careful follow-up of adolescents with history and symptoms of endometriosis is mandatory, as it can be a lifelong disease. Thank you, Vidya, for your nice presentation and informative and intuitive presentation. Thank you once again.
Thank you very much, both the chairpersons, for your excellent remarks on this presentation. Actually, we are almost at the end of our session. I would like to express my gratitude to the organizer that they have given chance to me be a moderator of this wonderful session. And It's very nice to me to meet all these brilliant personalities and to hear from you. Thanks indeed. Now, I would like to request Dr. Sharmin Siddiqa Islam, reporter of this session, Assistant Professor Gynae, Anwar Khan Medical College, to wrap up this Symposium 8. Thank you all again.
Thank you, Madam, for giving me the opportunity to closing the session. Actually, this endometriosis, it is the tear of million women, and we are facing a lot of complications day by day. They are increasing. And this kind of conferences that is held in our country for the first time, there are so many foreign learned professors are talking, and we are getting the opportunity to see their several videos, the surgical techniques, and the recent updates. We are really blessed to getting chance to see all these things at a glance here. And I would like to thank our honorable chairpersons. I would like to thank our speakers and for their excellent deliberation, which has enriched our knowledge enormously. And I would like to give special thanks to our moderator, Madam. And now I think this is the last session of Hall B. That's why I am going to declare the closing of the session. Thank you. Thank you all. Assalamu alaikum.
Thank you. Thank you, everyone, for the excellent session. Thank you. Professor Akira, Mr. Fuki, Sherry Madam, Dilruba Madam, thank you very much. Runa Madam, thank you. Madam, thank you. Thank you.
Recording stopped.
Thank you. We can join in the Hall A, because Hall A, there is a very interesting topic is ongoing. What is the management of endometriosis after the age of 40? And the president of European Endometriosis League is giving the presentation. So please welcome everyone in Hall A. Thank you.
Thank you, Sharma.
Okay, we are joining.
We will jump in the Hall A. Okay.
Thank you, Professor Akira. Thank you for your nice presentation.
Thank you.
You are watching Raj TV.